Welcome back to this last video on articulations. And I'm going to be talking about movements and some other things related to joints, but I want to take a moment just to revisit the angular joint movement because I don't think I gave it enough emphasis previously. And so basically the movement at a joint is determined by the shapes of the bones at that articulation. So when talking about non-axial movement, what that means is no angles, no flexing, extending, abducting, adducting, only linear, only sliding. So the only type of joints that do this are planar joints. The second type are the uniaxial joints, also known as monaxial, and these are ones where we are going to have rotation, but only in one plane. For instance, we can flex and extend. That's all in the same plane. Or we can go medial or lateral. So examples of monaxial or uniaxial joints are our hinge joints and our pivot joints. Continuing on, our biaxial joints have 2 degrees of freedom because we can have movement in 2 planes. So we could have both flexion and extension in an anterior posterior plane, but we also could do medial or lateral movement, abduction or adduction. Okay, and so examples of biaxial joints are our condylar joints and our saddle joints. And the last one, our multi-axial joints have movement in 3 planes, and the only example of this is a ball and socket. So I hope that helps and gives you a chance to go back and check what you filled out in that table. So let me talk about the different types of movements in synovial joints and those words, those terms I just talked about. So the first one, when the angle of the joint changes, if the insertion of the muscle is moving closer to the origin of the muscle, in other words, the angle of the joint is decreasing, that is flexion. And if it's increasing, the 2 ends are moving further away, that would be extension. If the body part is moving in relationship to the midline, if we are moving away from the midline, for instance, you're starting to do a jumping jack up like this, to take away is like to abduct someone. So this is called abduction. Now, if you are coming back down the second half of a jumping jack and you are putting things together, you are adding things together, that is called adduction, adduction. Another angular joint is when we move in a circle, making a cone shape that only happens in our 2 ball and socket joints, where basically we are putting a whole bunch of joint movements together to make a movement known as circumduction. Rotational movements are when the bone turns on its long axis, okay? So here in your shoulder, you're turning it towards the midline would be medial rotation. If you're turning it away from the midline, that would be lateral rotation. Looking at movements that are only found in the extremity, if these were your feet, when the bottoms of your feet turn inward, that is called inversion. So it has nothing to do with you looking at the top of the feet, because the top of your feet will be turning outward in inversion. It's what's happening to the bottoms of your feet. Turning inward, that's inversion. Turning outward, that is eversion. At the ankle, this is the only joint where we're not going to be talking flexion and extension. Both joints are considered a type of flexion. If the ankle joint is going what you might think is extension to, like for instance, you're going up on tippy toes like a ballerina, that is called plantar flexion. It's not called extension. Whereas if you are bringing your foot back as if you're doing some yoga move, that would be called dorsiflexion. That only applies to the ankle joint. When you get to the toes are still going to be flexing and extending. In the forearm, this is the only place where we have the radius moving around the ulna, where we have pronation, and if you're in anatomical position, you are automatically in supination because the two bones are parallel to each other. And a movement which only applies to the thumb is that the thumb, the metacarpal of the thumb can actually move the thumb so it can meet up with the other digits. And this is called opposition. And the movement is actually happening down here between the first metacarpal and the carpal bone. So I don't know if you can see that you're not actually moving this. It's this joint right here. Can you see that? It's this joint right there that's allowing you to do the opposition. And the next one is where the wrist moves away or towards the midline, okay? And so a lot of people still call this wrist adduction and wrist abduction, but some people will also call this ulnar flexion and this radial flexion. Put them in red there because I will take either term, although personally I much prefer adduction and abduction. Okay, and also don't forget you can abduct and adduct your digits as well. All right, so movements related to the torso. If the trunk or the neck is moving anterior, that's going to be flexion. When you are in anatomical position, you are in extension. So when you look up at the sky at night to see the stars, that's not called extension, that's called hyperextension. Okay. And then if the trunk moves to one side or to the other side, that is called lateral flexion. So you can have lateral flexion of your trunk, you can have lateral flexion of your neck as well. And then if the torso turns at the waist, whoop, and whoop, okay. You can't really call that medial and lateral rotation because you are turning in the midline. So if you are turning towards the left, it's called left rotation. If you're turning towards the right, it's called right rotation. Okay. Couple of more movements. If you are moving a body part in the vertical plane, if you're moving it upward, you are elevating it. For instance, when you close your mouth, you are elevating your mandible. And when you open your mouth, you are depressing your mandible. So you can do the same thing with your shoulders. And if you are moving in a transverse plane, if you are moving in an anterior direction, like getting out your chin, that would be protraction, and pulling it back is retracting. So we can do that here with our mandible. We also can do that with our scapula. So for instance, that's your scapula retracted. Okay. So looking at synovial joints, the stability of a synovial joint depends on a couple of different characteristics. First, it has to do with the shape of the articular surface. If it is very shallow, it is much more likely to dislocate, whereas it is very deep, a very deep socket and very snug, it would have more stability. The second thing has to do with the number and position of ligaments. The more reinforcing ligaments you have, the more stability you have. Now, if you have stretched those ligaments, they are stretched forever. And by stretching them, basically you get about 5% free. There's no elastic fibers in the ligaments. It's like collagen, okay? So if you stretch collagen more than 5%, it doesn't go back to its resting place. And so if there's no other support, you're going to have an unstable joint, and you can do funny things to it. Like I can make a 90-degree with my thumb because I have torn that ligament there. And the third and super important part that has to do with stability has to do with muscle tone. The tendons crossing the joint, this is primo, and this is the part where physical therapy comes into play and where people don't want to do it. For instance, for knee stability, if you want to have a more stable knee, you need to work on your quadriceps and hamstring muscles because their tendons are crossing the joint. So technically, they're not ligaments, they are tendons. They are both dense, fibrous, connective tissue. And there are proprioceptors in the muscles which will actually correct and help with the stability of that joint. So you don't have to become a muscle guy like this, but this is super important for your shoulder and your knee and your ankle and foot. So what does that mean? The most mobile joints have the least stability, and the least mobile joints have the most stability. So in this case, you cannot have your cake and eat it too. You either have a shape designed for mobility and have all the structures related to that, or you have all the structures which make the joint super stable, which decreases the mobility. Okay, so the last part of this, I want to talk about arthritis, and there are a few types of arthritis, and I want to talk about the 3 most common types of arthritis. And of these, the most common by far is osteoarthritis. And in fact, if your parents, grandparents make it to the age of 70, 85% of them will have osteoarthritis. And the reason for this is just our garden variety wear and tear arthritis. So congratulations, you have lived to a ripe old age. But as a result of all the activities you have done your entire life, you have had wear and tear on your joints. And no, popping your joints has nothing to do with making arthritis. So if you have been any type of an elite athlete or professional athlete, your chance of developing osteoarthritis is pretty close to 90, 100%. Okay, and it's going to affect you at a much younger age because you have had more damage. So what happens with this wear and tear is the articular cartilage degenerates over time. And what happens as a result of that is you end up having like bone on bone. And perhaps you've heard people like when they sit down, you can hear their knees creaking and you can hear the, that is bone on bone. That is not a good thing. And so this is much more common in our larger joints, our hips, our knees, and our spines, but we also get some in our fingers. The most important thing you can do if you have osteoarthritis is exercise. What's the number one thing people with arthritis don't want to do? Exercise. So when I say exercise, I don't mean if you have arthritis, you should be exercising exactly the same as somebody who doesn't. That's where a good physical therapist comes in, and he or she will determine by putting a hand on the joint whether or not you can feel the friction of bone on bone, and you will figure out how to work out those muscles without doing that. You will decrease the range of motion. You will work with more weights in the narrow range of motion, but you will build up those muscles, which will help stabilize this joint. The second type of arthritis is rheumatoid arthritis, and this is what we call an autoimmune disease. What does that mean? It means your immune system, for some reason, is thinking that your synovial joints are not part of you. And so they send out inflammatory components which are going to attack the synovial membranes. And they're going to release enzymes which will then destroy the cartilage. And so what happens with rheumatoid arthritis is the entire joint gets totally destroyed. It is very common in small joints, especially in the hand. So if you look at this elderly lady's hand, I know you can see some enlarged joints here near the fingertips, but I want to look here at the knuckle joints. And they look enlarged, but that's not the real problem. Look at what happens when you lay your hand out, your fingers are like this, but that hand has what we call ulnar deviation in that, and I can't even do it. It's like take this and angle it even more so all the digits are angling towards the ulnar side. And the reason why you have that severe ulnar deviation is look at an x-ray up here. And what you can see is all of those joints basically were dislocated and the bones have fused in this abnormal position. And the thing about rheumatoid arthritis is that it's more common in women because almost all autoimmune diseases are more common in women. And there's no cure for it. There are some treatments for it to try to cut down on the inflammatory components. The third type of arthritis I want to talk about is gouty arthritis, which is the arthritis you get with a disease known as gout. And gout means you have high levels of a substance known as uric acid. So what is uric acid? When your nucleic acids, your DNA, your RNA get metabolized, one of the byproducts is something called uric acid. And if you have high uric acid levels in your blood, it can crystallize and you will get crystals that form in your kidneys, in your joints, and in your skin. And so I put a picture here where you can see these little white depositions of gouty the uric acid crystals. The classic joint that gets affected with gouty arthritis is between the metatarsal and the proximal phalanx of the large toe. And so this brings people in say, my big toe hurts, I didn't stub it, I tried new shoes and it still hurts. Pain is the biggie here. Now the reason I want to talk about gouty arthritis is because high uric acid levels are a side effect of a high protein diet. So up until about 10, 15 years ago, gouty arthritis was only typically seen in rich men who like to have a lot of steak and red wine dinners, okay? Or in women who did that, the whole bacchanalia thing. Okay. Now it is seen in a lot of college students because a lot of college students are on high protein diets. For some reason, you think you are protein deficient and you'll get protein powder. You're going to the gym to work out. Yeah, I'm gonna take some protein powder. If a little is good for me than a lot. It's like you eat 4 eggs for breakfast. Oh my God, you have so much more protein than your body needs. And also, along with all of that high protein diet and the red meat, you know, hamburgers are a red meat. There's a lot of beer consumption, which acts like wine does and potentiates the effect as well as slightly dehydrating you, which makes your uric acid levels go up. So we're seeing a lot of gouty arthritis in college age students as well as a second peak in your 50s. So the last slide I want to talk about has to do with joint trauma, specifically the knee, where with one blow to the side of the knee, and this is a major foul in football and every sport. And the reason why you need to learn to play by the rules, because in one lateral blow to the knee, you can tear the medial collateral ligament, the medial meniscus, and the anterior cruciate ligament. And this knee will never be stable for the rest of that person's life. So if that happens when the person is the prime athlete and is 25 years old, that person will have an unstable knee for the next 70 years of his life. And there is no surgery that can return this knee back to normal. So please, you're only given one body, respect your body and respect other people's bodies. And with that, we are done with articulations. And I want to thank you for all your hard work. And I will see you again for the next class.